Hello everybody, I am Dr. Chiara Ascu from Mercy Hospital in Iowa City. Today I'll present to you discussing goals of care and medical decision making with families of patients with impaired decisional capacity. I do not have any financial disclosures to make. At the end of this presentation, you will be able to identify when goals of care need to be discussed, evaluate medical decision making, conduct a goals of care discussion, and document the goals of care and advanced care planning. During the presentation, I will ask you to pause a few times and pretend that you are the clinician or you are the person who has to take the decisions. So please have a pen and paper available and write down what would you do if you were in their shoes. It is a good exercise and gives you a taste of what it's like to go through a difficult process of talking about goals of care and taking decisions for somebody else. Let's start with a case that I will follow throughout the whole lecture, so it does make more sense for you, and you would be able to understand better what's going on and how to do the discussion. Mrs. Smith is a 79-year-old widow female who resides at a nursing home for the last couple of years. She has a 54-year-old daughter who lives out of state and visits her every 3 months. She also has a younger brother who visits her every 2 weeks. She does not have a living will. As medical history, she has advanced dementia, hypercholesterolemia, rheumatoid arthritis, osteoporosis, chronic pain from compression fractures, frequent UTIs, and recently had 2 bouts of pneumonia and has been hospitalized twice for it in the last 2 months. She is at the point where she does not recognize family members, not even her daughter or brother, and she barely communicates. Her vocabulary is reduced to a few words that she keeps repeating. She no longer feeds herself, doesn't seem to enjoy food anymore, has no appetite, and lost about 20 pounds in the last year. She looks pale and is weak and tends to sleep quite a bit. She does have pain from fractures and from arthritis, and you can hear her moaning at times. She recently developed diarrhea, and staff noticed blood in her stools. She does take a number of medications, Namenda, a statin, the medication for rheumatoid arthritis, for osteoporosis, and time to time she is on antibiotic either for her UTI or the pneumonia. She also gets pain control, but is not taking opiates, but rarely. At this point, there are many decisions to be taken, considering that her condition has declined significantly during the last year in particular. At this point in time, the team is interested in finding out what the new goals of care are for Mrs. Smith, considering that her medical condition has deteriorated during the last year. Then she does not have much quality of life at this point. They asked her daughter and her brother to participate in a discussion for establishing the goals of care and then what the next steps will be. Let's talk a little bit about goals of care. Sometimes goals of care are given a very narrow meaning, like code status, when in fact they include decisions about specific treatments, about intensity of care, about advanced care planning. They usually vary from person to person. For example, some people want to live as much as possible, no matter what the side effects of the treatments are or what the quality of their life is. Other people, though, prefer to have quality rather than quantity of life. Of course, the goals of care are influenced by individuals' values and preferences and impact both the quantity and the quality of life. The goals of care concern not only the goals at the end of life, but also how the patient wants to live for the rest of their life, and in particular when they have a chronic illness. And they are different from discussing prognosis or delivering serious news. In fact, it is highly recommended to not discuss goals of care when you just delivered bad, serious news. For example, after you just informed the patient that they have cancer, it's not a good idea to immediately, in the same session, to start discussing goals of care. Why we need to discuss the goals of care? Why do we need goals of care? Understanding the patient's goals of care allows the team to provide the care that is most in line with patient's wishes to help patient achieve what matters to him or to her. Some goals of care are very personal, such as attending certain events, completing a book, or mending relationships. Others are medical in nature, such as pursuing or not pursuing treatment for cancer, or wanting or not wanting to be intubated or to have a feeding tube placed. There are a number of advantages of discussing goals of care. First of all, it will facilitate advanced care planning, improve satisfaction with end-of-life care, reduces use of potentially inappropriate life-sustaining treatments. For example, will it make sense to intubate a patient who has an end-stage lung cancer who is already in terminal delirium or not? If patients and family understand exactly the consequences of the intubation, the risks, the prognosis, they may choose, in fact, not to pursue the intubation at that point. Discussing goals of care also helps the patient, the family, and the caregivers to come to terms with the reality of the illness. It gives them time to process the situation and their own emotions, which also improves the satisfaction and quality of care for everybody, patient, families, medical team also. When should we discuss goals of care? It is highly recommended to do it as early in the illness trajectory as possible, especially in the case of a potentially life-threatening illness or risky treatment. For example, a high-risk surgery or chemotherapy. There is also recommended to do it when there is a limited life expectancy, such as in the case of, let's say, pancreatic cancer, when 3 months life expectancy is not unusual. Also when people disagree. For example, in Mrs. Smith's case, her daughter wanted to do everything possible to prolong her life, while her brother, in fact, opted more for comfort care. We should also discuss it regularly as the health status changes during the course of the illness. And another time when we need to do that is when there is a change in the setting of care. For example, the patient being discharged from the hospital to the nursing home. So who should initiate the discussion? Ideally would be the primary care clinician who knows the patient for a long time, or the specialist who follows the patient longitudinally for a serious illness. Again, the sooner the discussion takes place, the better it is, as it allows the information to be digested and the emotions to be processed without the pressure of time, without being transactional or adversarial, which sometimes happens in crisis situations, such as an emergency admission where the critical care doctor or the hospitalist, who basically don't even know the patient, are the ones who need to have that discussion. No matter who leads the discussion, good, effective communication is key. So what will be the barriers in discussing the goals of care and why that doesn't happen more often? First of all, there are time restraints. A 15 minutes visit in the clinic does not allow this kind of conversation that takes time and active listening. Those discussions are also stressful and emotionally charged, both for the family's patients and for the clinicians. There is also the fear of negative consequences and distressing the patient and the family. And most clinicians and medical staff is well aware of that and quite concerned about that. For example, in the case of Mrs. Smith, Her daughter was often seen crying when visiting her mother. Approaching her to discuss goals of care can be distressing for the clinician. Some clinicians unfortunately feel unqualified or inexperienced to have this kind of discussions. Sometimes it feels like climbing a mountain and having a long, difficult path in front of you. However, I don't think we should be allowing us to be deterred by that. We'll feel more comfortable and in control if we develop a systematic approach before the meeting, if we know what and how to discuss. So it's really important that we review the chart, we know exactly what points we want to make, and eventually refer to toolkits that will allow us to make the discussion much easier. And I'll give you a few references at the end of the presentation. We also want to approach the discussion with care and sensitivity. Where and how to discuss the goals of care. First of all, I think it needs to take place in an appropriate and private setting. It's not a discussion that can take place on the way to the door or in the hallway. It's also recommended that we all sit down so we don't tower over the patient or family. And we want to show that we actively listen and understand, and takes time and patience. When the patient is able to take medical decisions, of course the patient will be invited, and everyone else that the patient wants to be involved. In Mrs. Smith's case, the patient definitely is not able to take a decision, but her family members have both been invited, considering that they were both quite involved in her care and visited, especially the brother visited quite often. Her daughter also got numerous updates by phone. We also recommend involving the extended care team if possible, so everybody's on the same page. I recommend allowing plenty of time and eliminating the interruptions, so turn the pagers off. And make sure that you are very clear, concise, and specific. At this point, I'll invite you to imagine that you are in their shoes, and I would like you to pretend and imagine how would you like to be treated. So that will give you a clue on what you need to do to set up a good discussion atmosphere. In order to make your life easier, we can use the systematic approach: remap, reframe, expect emotions, map out the future, align with values, and plan treatments that match values. Let's start with reframe. First, we need to assess patients' family, caregivers' understanding of patient's condition and prognosis, and also their acceptance of those. You can use open-ended questions such as, what is your understanding of what the doctor told you about your illness? Then we need to assess how much the patient and the family wants to know and discuss. Not everybody is ready to discuss goals of care, and there are patients who don't even want to take decisions, and they ask somebody else to take the decisions for them. You can ask the question, how much and what type of information do you want to know? Some people want to know how much time they have left, what to expect, or both. It's really important to assess the expectations and to clarify the misunderstanding, to figure out what the patient considers to be a tolerable versus intolerable quality of life or treatment side effects, what people consider to be reasonable or unreasonable for them and for their quality of life. Expect emotions. Attend to patients' and families' emotional needs, and watch for the emotional cues and for their affect. You will easily see feelings of loss, of fear, of anger, guilt. Pay attention. Are they fidgeting? Are they crying? Listen actively and address the emotions, as it's more helpful to address the emotion than to improve their understanding about the illness. We strongly recommend acknowledging and naming the emotions. We need to allow strategic silence and give time to react, and don't rush to cover up the silence. Absolutely consider having tissues on hand. In order to make it easier, we can use the acronym NURSE, basically naming the emotion, understanding, respecting, supporting, and exploring. When we talked to Mrs. Smith's daughter, we noticed that she was anxious. So we told her something like, "You look anxious. What frightens you?" This is a normal reaction, and if I were in your shoes, I would probably have felt the same. Let's see how I can help you. And in fact, what would you like to know from me? Let's map out to the future and see what road we are going to take at this point. Once we clarify the emotions and answer the questions, we need to clarify the goals. And I think we can do that by starting with questions such as, what is the most important for you? Or what concerns you about the future? Sometimes there is a conflict between what the patient and family wants and what is realistically and medically possible or likely. For example, Mrs. Smith's daughter wanted her mother to get better and be able to recognize her again, which definitely is an impossible goal to reach. The next step will be to recommend treatments and interventions and to identify realistic goals and outcomes. For example, some people will want to have comfort care, others will consider withdrawing all interventions, or others will want very aggressive treatment. The goals of care, as I said before, they vary from person, from, for example, somebody wanting to live as long as possible, to other people who just want maximum comfort and no aggressive treatment, and everything in between. We need to be concrete and avoid saying, do you want us to do everything possible? What everything possible does it even mean? At this point, I would like you to stop the recording and write down what you think could be the goals of care for our patient, Mrs. Smith. What if the discussion does not go well? Well, in that case, the best is to postpone the discussion and give people time to think more. In Mrs. Smith's case, the daughter wanted her mother to live as long as possible, and her brother wanted comfort care. So they couldn't negotiate or reach a conclusion at during the first meeting, and so the discussion was postponed. Sometimes the family members get angry or frustrated for various reasons, sometimes social reasons, psychological, or their own mental health issues. We have to keep in mind that being in such a situation is very stressful, and frustration, anger, and sometimes guilt are to be expected. We also can involve the third party, for example, the palliative care team or an ethical committee. Next step will be to align with the values, to show that we understood what is important for the patient, for the family, and that can be easily accomplished by, for example, repeating back what the person said. For example, so you said you want mom to be fed by a tube. Did I understand you correctly? You are afraid that she will not be able to, that she will die because she's going to be hungry. We need to focus on what we will do to help achieve the goals and avoid giving false hope because we feel sorry for that person. I often use the saying, let's hope for the best, but be prepared for the worst. If asked for prognosis, I recommend giving intervals and not try to be very precise, as none of us can read the future. So it's best to say the prognosis is days to weeks, or weeks to months, or months to year, rather than say it's exactly 2 weeks. Usually it doesn't happen like that. And also we need to make clear what things we cannot do. Once we figured out what the goals are, we need to prioritize those goals. And we need to invite the family to talk about options of treatment. We also gonna want to make a clear and concise plan with very specific treatments. And that's not enough. In fact, a good thing to do is to ask, what do you not want to happen? For example, you may find out that the patient doesn't want to die in the hospital, or doesn't want to be hooked on machine, or some other things. So it's really important to also figure out what they don't want to happen to them. Once we clarified the journey and the goals, we prioritized them, and we made a clear plan with specific treatments, we need to document it to make sure that everybody knows what the goals of care are and what the plan is. If it's not documented, it did not happen. And more so, we need to file them in a place where they can be easily seen and accessed. And also, we might want to, in fact, we strongly recommend that the other team members are informed, and the other clinicians are also informed and involved, so everybody is on the same page. What not to do? I think we shouldn't start too late in the illness trajectory, and we shouldn't expect too much too soon. Again, the news need to be digested, the emotions need to be processed, and people need time to take decisions. We should avoid discussing goals of care when we have just delivered serious news or bad prognosis, and again, allow time to process the information. Let's move on to competence and decision-making capacity. These two terms are sometimes used interchangeable. However, I want to clarify that competence is a legal term and is determined by the courts. Decision-making capacity is a clinical assessment. Any physician can determine it, and refers to a very well-defined decision. It's basically a person's ability to understand and make a decision. Of course, that's not static, it's fluid, and needs to be reassessed. For example, when Mrs. Smith was just diagnosed with mild dementia, she probably would have had the capacity to decide if she wanted, for example, workup for the cancer or not, or if she wanted treatment for her dementia. But at this point, she clearly is not able to take those decisions. Based on the autonomy principle, every patient has a right to refuse or to accept treatment. And a psychiatric diagnosis by itself doesn't make a person incapacitated. The patient is assumed to have capacity until proven otherwise, and the burden of proof lies on the clinician who performs the assessment and not on the patient. Applebaum came with 4 criteria to help us better assess if patient has decision-making capacity. And those 4 criteria are: the patient needs to be able to communicate a choice, to understand the relevant facts, to reason about the information given to him or her, and to appreciate the consequences. Let's look at what conditions can affect the decision-making capacity. Basically, any condition that affects cognition may impair decision-making capacity, and no single condition invariably predicts impaired capacity. For example, even in the early stages of dementia, the patient may be able to take certain decisions, maybe not others. For example, they may decide if they want to have treatment for the UTI, but they may not be able to decide to decide over, for example, high-risk surgery or treatment for cancer. Examples of conditions that affect cognition and implicitly the capacity of taking decisions are dementia, which is the most cause of impaired capacity, delirium, that is most of them are reversible, and you may find that the patient is unable to take the decision at this moment, but once the delirium is cleared, he or she is able to take the decision with not much problem. There are some psychiatric conditions. For example, a patient who has schizophrenia or a patient who has a manic episode and has bipolar disorder. During that episode of mania, the patient may not be able to take decisions for himself. However, once the episode is treated, he might be very well equipped to do it. Then there are traumatic brain injuries, intellectual disability, and it's quite common at the end of life the cognition to be impaired and the patient to have harder time or be impossible to take a decision regarding goals of care or treatment. What to do when a patient lacks capacity? Well, in that case, we have the ethical obligation to seek a substitute decision maker, a surrogate. So the surrogate decision maker ideally would be chosen by the patient in advance. And that's why it's important that we talk with the patient prior to losing her capacity to decide. A decision maker should be identified for all patients, even if at this time they are able to take decisions. If we know there is going to come a time when they are not going to be able to take decisions, then it's a good idea to identify who they want to be their decision maker. The decision maker, of course, is a patient representative and will make health decisions based on the substitute judgment. So, in the case of Mrs. Smith, who should take the decision? Should be the daughter or the brother? Well, the hierarchy of proxy role is the spouse, which she doesn't have as she is a widow, adult children, which will be her daughter. If she didn't have children, will be her parents, which most probably, or surely will not be alive. Next will be the siblings or friends. In her case, both the daughter and the brother were very involved, and they both decided that they want to take decisions together. Challenges of the medical decision making. First of all is the emotional part. Many people fear that they are killing that person. Like Mrs. Smith's daughter was afraid that if her mother didn't eat, she will die because she was hungry. Other people have second thoughts. They will take a decision and they come back and try to reverse it. It's also challenging because the decisions are based on a limited outcome data and involve multiple variables. It's ideal when patients express their wishes, but that doesn't always happen. In fact, most of the time doesn't. So what the patient would have wanted if he could speak to us now is a very good question to ask when we don't have information. What is in the patient's best interest is another question that we should use. If we don't have any information, we need to look at the advanced directives, look back at what statements patient has made. For example, in the case of Mrs. Smith, her brother said that she often said that she preferred to die than lose her mind. We also need to look at patient general values and beliefs, how they lived their lives. For example, in the case of Mrs. Smith, she always valued independence. What if the decision maker cannot take decisions, cannot decide, has a very difficult time to do that? Then the decision should be based on the best interest of the patient, and sometimes we need to consider a limited time trial. And of course, revisit the goals of care. The most frequent and most difficult decisions to take are related to eating. Should a feeding tube be placed or not? This is probably the most distressing one. Second is about medication. For example, in the case of Mrs. Smith, she was taking a statin and also Namenda for her dementia. And the daughter had a difficult time deciding that those could be discontinued. It's also difficult to decide the level of resuscitation, especially if is chosen to do not resuscitate. Many times people equate the do not resuscitate with do not treat, which is not true. Do not resuscitate means exactly that. Do not resuscitate. The patient still will continue getting treatment though. Another difficult decision is to hospitalize or not hospitalize. For example, in the case of Mrs. Smith, if she has fever again, should she be hospitalized or her symptoms should be treated at the nursing home? This way avoiding multiple tests, treatments, removing her from her own environment. They're also difficult to decide if to intubate or not, or to pursue or not pursue dialysis. Please stop again the recording and write down what you think the family of Mrs. Smith decided in regard of feeding, resuscitation, DNR, or DNI. Let's talk a little bit about advanced care planning. This is an ongoing process. It documents future healthcare choices, may include completion of an advanced directive like living will, durable power of attorney for healthcare, physician order for life-sustaining therapies. It also would include in the hospital DNR, out of hospital DNR, and there are advanced directive registries that we should all be aware of. Here you have the web address for the physician order for life-sustaining therapy in Iowa, and I strongly encourage you to go on the site and also to take a look at the forms. In all this process, the clinician is expected to provide information based on the existing data, on the clinical experience, like the natural course of the illness, the prognosis, the priorities. We need to give the same information to the surrogate as we will give it to the patient. And definitely we need to support them in that and have a compassionate, provide a compassionate support. In the end, I would like to recommend you a few resources. And the first one is the Conversation Project website, where you can find a toolkit to help you lead a goal of care discussion. I will also provide you the Northwestern link, where you can find a lot of information about end-of-life care. I strongly recommend reading the book Being Mortal by Atul Gawande. I think everybody should read this book. And also a new one called When Breath Becomes Air by Paul Kalanithi, who is a memoir written by a doctor who was diagnosed with metastatic lung cancer, and before dying he wrote his own struggle. He wrote about his own struggles and his family's struggles with the diagnosis and the decision making. And this is the end. Thank you.